Good morning to all our delegates and friends in Kenya, and good noon to everyone in India. This is Dharmendra Joshi, once again your host for the day, and I welcome you to this IMDI webinar series, concurrently organized with the virtual trade show titled Medical and Healthcare Africa 2020, focusing on medical, healthcare, and anti-epidemic products. A very fruitful day one yesterday saw more than 350 participants join the webinar and a large number of visitors to the virtual trade expo. We had the pleasure of having excellent information and vision sharing from Sri Rajiv Nath, the forum chairman and founder, Association of Indian Medical Device Industry, Dr. Eric Ruto, the vice president, Kenya National Chamber of Commerce and Industry, Dr. Elizabeth Gitau, the CEO of the Kenya Medical Association, Sri Mahesh Desai, the chairman of Engineering Export Promotion Council India, Mr. Joshpat Mabua, on behalf of Ms. Mercy Wagangi, the Chief Administrative Secretary of Ministry of Health Kenya, and finally by Mr. Ravi Srivastav, the CEO and Director of Omni Lens Private Limited, Ahmedabad, India. A wealth of information and learning from all these experts, all leading to highlight the fact that India is a reliable source of medical device products and technologies for Africa. Truly so, as the huge population of Africa as a continent, with about 26 of the 54 African countries having crossed middle income status, and 5 of world's 12 fastest growing economies being in Africa, Africa is rightly the destination for Indian entrepreneurs. India, and in particular Gujarat, has always had the fortune of having very ancient business relations with Africa. And the African people definitely have more faith, trust, and affinity to Indian people than any other place in the globe. Indian business houses have a great opportunity of taking benefit of the huge business potential in Africa in the coming years. Today is the second day of this webinar, and today's theme is safety and risk management for healthcare professionals. Let me once again introduce to you the organizers of this webinar. The webinar is organized by Classic Computer Services, a company providing information resources for medical technology and markets through publications, internet portals, exhibitions, conferences, and market research since the last 25 years. Timely information. They have been publishing a techno-economic news magazine titled Medical Plastics Data Service for medical plastics, diagnostics, and the pharmaceutical industry, being published since 1994, and also the company promotes 2 internet portals, www.medicalplasticsindia.com and www.medisourceasia.com. The organizers of the virtual trade show, Radical Communications, led by Mr. Sanyal Desai, have established themselves as one of the renowned international exhibition and conference organizers in India and Kenya by organizing various exhibitions in varied business sectors in the domestic as well as the international circuit. Radical Communications, with their experience of more than 10 years in the exhibition industry, have partnered and represented India at various global exhibitions that have taken place in different parts of the world. This virtual trade expo and webinars are supported by the Ministry of Health, Republic of Kenya, the Association of Indian Medical Device Industries, in short AIMED, the Medical Association of Tanzania, Engineering Export Promotion Council of India, EEPC India, the Medical Association of Kenya, Critical Care Society of Kenya, National Health Authority, Government of India, the Kenya National Chamber of Commerce and Industry, and the Association of Kenya Medical Laboratory Scientific Officers. To begin the day today, let me invite Mr. Sanyal Desai, the Managing Director of Radical Communications, one of the organizers of this event, to give his welcome speech, please. Mr. Sanyal Desai.
Thank you so much, Mr. Joshi, for your always, as usual, wonderful seminar moderating whenever you operate. We always cherish to associate with you.
Thank you.
Ladies and gentlemen, it is my privilege to give a welcome note today in front of a lot of eminent speakers and panelists on this platform. Let me first of all welcome His Excellency Mr. Willie Bett. Mr. Willie Bett is a High Commissioner of Kenya to India, and we are lucky to have him here in India. And we also have a lot of good cherished moments when he was in Kenya and when he started his journey in India. So we have a lot of attachment with the Embassy of Kenya as well as the Kenyan government as well. And personally, I feel that Kenya is my second home after India. I would say that because we do a lot of activities there. We have our own office in Kenya since last 6-7 years, and we look for very strong and continue bilateral relationship between India and Kenya. I would also like to welcome Dr. J.L. Meena. He also was in Gujarat, and we are also lucky to have associated with him in one of our past exhibition and webinar conference which we have done with Mr. Pandya as well. So welcome Dr. J.L. Meena also. We have Dr. Karnav Patel. I would like to welcome Dr. Karnav Patel. He's from Apollo Hospital and AIM Hospital. He's doing a lot of services over there. Then we have Mr. Safari Kiti. He is the chairman of Association of Kenya Medical Laboratory Scientific Officers. So welcome Mr. Safari also. And we also expect Mr. Lawrence Mamiti very soon with us. He is also a member of Association of Kenya Medical Laboratory Scientific Officers. And lastly, Mr. V.R. Patel is a retired Chief Environmental Engineer and CEO of Veer Environment Management. We have also associated with Mr. V.R. Patel when he was giving his honors services to Gujarat Pollution Control Board. So thank you so much, everyone. Thank you all the exhibitors, all the visitors. This is a new normal, the virtual platform, and with somewhat positive and negatives, somewhat pluses and minuses. We are going ahead towards this, and I think we had a very fantastic first day in terms of good numbers of visitors and webinar attendees came to this platform, and we look forward another 4 days fruitful visit flow from across the world. Thank you so much.
Thank you.
Thank you very much, Mr. Sanyal Desai. This effort has been very successful, and we look forward to more such events to help bilateral trade between India and Africa. I now invite Mr. D.L. Pandya, the webinar convener and the Managing Director, Medical Plastic Data Services, the other organizers of this event, to give his address, please. Mr. Pandya, please.
His Excellency, Mr. Willie Bett, Dr. Meena, Dr. J.L. Meena, Dr. Karnav Patel, Mr. Lawrence, Mr. Safari, Mr. V.R. Patel, dignitaries and delegate friends from Africa and India, good morning and good afternoon. Welcome to this second webinar focusing on safety and risk management for healthcare professionals. Safety and risk management for healthcare professionals was never more important than in the present COVID-19 pandemic situation. As we know, healthcare is one of the fastest growing sectors of the economy, and women represent nearly 80% of the healthcare workforce. Healthcare workers face a wide range of hazards on the job. On and above the COVID patient exposures, they are including needle stick injuries, harmful exposures, latex allergy, risk associated with biomedical waste management, hospital-acquired infections, sterilization-related risks, and so on and so forth. Healthcare workers experience some of the highest rates of non-fatal occupational illness and injury, exceeding even more than the construction and manufacturing industries. This signifies the importance of managing safety and risk management at all levels for the healthcare professionals. Considering this, the national this conference, this webinar on safety and risk management for healthcare professionals. We have been organizing such events for the last 4 consecutive years, and this is the 4th conference in the form of this webinar. The objective is to help companies from India and Africa to face challenges post-pandemic and the new normal situations in the coming future with 3 different themes. The target or the focus of this webinar is also on the healthcare services sector, and I hope that the delegates and the visitors of this exhibition, this virtual exhibition, will certainly benefit from the participation in this very important subject on health, safety and healthcare for healthcare professionals. Thank you very much. Mute here, mute. Dharmendra bhai, mute here.
Yeah. Thank you, Mr. Pandya. Your experience in organizing such conferences and seminars shall definitely help our entrepreneurs. Friends, it is a very proud privilege for us to have His Excellency Mr. Willibet, the High Commissioner of Kenya to India, with us here as today's chief guest. He is also the High Commissioner designate to the Socialist Democratic Republic of Sri Lanka, the People's Republic of Bangladesh, and the Republic of Singapore. Ambassador Bet has over 27 years of experience as a senior bank manager, managing director, and a senior government official. He holds a bachelor's degree in economics and sociology and master's in business administration in marketing, both from the University of Nairobi. He also has undergone several professional courses, including in banking, market research, and prestigious advanced management program jointly organized by the Strathmore Business School in Nairobi, Lagos Business School in Nigeria, and the IESE Business School in Barcelona, Spain. He is a member of the Chartered Institute of Marketing, Marketing Society of Kenya, and the Kenya Institute of Management. May I humbly invite His Excellency, Mr. Willibet, to give his address, please. Mr. Bet, please.
Sorry, I hope I can,
Yes, sir, you are audible.
You can hear me now.
Yes.
Thank you very much for those kind introduction, Mr. Joshi. The organizers of this webinar and the delegates who have joined us today. Mine actually is to thank all of you and to thank the organizers for thinking of this interaction, which is happening at this point in time when things are not normal. I think COVID situation is teaching us on how to do things a bit differently. And we are struggling, all of us, to see how to adopt into the new normal. And therefore, some of the things, as we were talking today in a meeting I was in, is that most of the things which we are undertaking now will remain with us even in after COVID. Because COVID, we are going to see most of the innovations we have come up with remaining with us. And so I'm happy to join you today in this webinar on the discussion on healthcare, especially between India and Africa. I will be talking mostly about the Kenyan situation. I want to begin by saying the relationship between Kenya and India dates back to the pre-independence period, where relationship was basically on trade. And this kind of relationship has really grown and has made the Indian community part of the Kenyan tribes, which has officially been agreed and was declared not long ago. So the Indian community in Kenya are not Indians anymore, but they are Kenyans. And therefore, that puts Kenya in a better pedestal in terms of relationship between Kenya and India. And when you talk of Kenya-India relationship, the majority of the Indian community in Kenya are actually from Gujarat. And so, which is an historical fact, which dates back to pre-independence, where the Gujaratis were the first Indian community to come to Kenya. And so, it's not a new thing for Kenya then and India to collaborate on various areas. And therefore, the bilateral relationship between Kenya and India has been growing from strength to strength, thanks to the leadership of the two countries. And I dare say the level of cooperation existing now is all-time high. And this one is courtesy of the Prime Minister of India, Narendra Modi, and the President of Kenya, Uhuru Kenyatta, who took up the relationship and moved it to the next level. And so, as the people on the ground, ours is actually to leverage on that relationship, on that high-level relationship, to make sure that the business community really take place. Because it's another thing to have the frameworks put in place and the actual business to take place. And so, this webinar is one of the avenues where we would want to see actual business relationship develop between the people of India and people of Kenya. And we pride ourselves in Kenya as a stepping stone to Africa. The minute anybody steps in Kenya, you actually have the opportunity to access the rest of Africa, more specifically Eastern Central Africa. And it is because of the position we occupy in Kenya in terms of infrastructure, in terms of all types of communication, both by land and by sea and telecommunication. That has put us in a really better position to access the rest of Africa through Kenya. And so today I'm really very happy that we are addressing this issue of healthcare. Part of my brief being in India is to find out the magic of India, or what is this code which India coded right in the area of healthcare. And I've come to confirm it. Being on the ground, the health system in India is really vibrant. And that no wonder you find most countries sending their patients to come and get treated here in India. And it has come out more clearly this time during the pandemic, more than any other time in the past, because there has been some natural flow of patients coming to India for treatment and leaving. But now, given this situation, we can deliberately see the desperate nature of our patients all over wanting to come for treatment in India, and the kind of restrictions available is really not allowing that free movement to happen. And that takes us to a major point. What kind of relationship are we going to build with India such that we build all the capacity in Africa and more specifically for my case in Kenya? What partnerships are we going to build with the Indian businessman such that even during pandemics like this, the services of healthcare can still continue in our various countries? And so this issue has come out so handy at this particular period because of the challenges we are also facing going forward. As I mentioned earlier, the level of technology in Kenya is equally good, and therefore, even without physical, we can develop some innovations on how healthcare can continue in Kenya, even without physical movement. Telemedicine is one area where I would want to see partnerships happening between India and Kenya. But going back to the traditional partnership is the manufacturing sector in the area of pharma in India is by far very advanced. And it is challenging any other industry or any other country in the world. And so partnerships in those areas of manufacturing is really critical to the extent that we've seen in the past a lot of partnership with Kenyan companies with many other multinationals. But we have in the recent past seen the shift from other multinationals to the Indian multinational systems, the partnerships in the area of manufacturing of pharmaceutical products. And therefore, this is an area we would want to encourage more so. And I think this kind of interaction is going to expose more the private sector in Kenya, especially in the area of medicine, because it's really vibrant. The medical profession in Kenya is mostly in the hands of the private sector. And that makes the partnerships more easier. And so we would want to see more. And this platform and webinar and exhibition is going to be one of the means of ensuring that the private partnership between the Kenyan entrepreneur and the Indian entrepreneur come together and see in which areas are they going to collaborate. I know we have in the past, through Radical again being really a more dynamic company in terms of preparing and staging exhibitions between India and Kenya, and probably for together the interest of the entire Africa region. To see, we have also in the past looked at other materials which would help in the medical area, things that non-woven products. We have also been discussing those areas, and we are seeing that the health sector requires more, especially at this point in time. And so I want to say I'm very happy today when we have a situation, when we have an opportunity to interact with the Indian health system and see how they can collaborate with the private sector in Kenya. So the impact of COVID, as you all know, has been major in all sectors of the economy, not only in the health sector, but the impact has been felt all over. The growth rates now in most countries are very low, or are below target, courtesy of COVID. But as I told you earlier, the impact of COVID as a disease itself and as a way of restricting movement of patients has been dire. As I told you, for the case of Kenya, the number of patients who would have wished to be in India for treatment is so huge. And so the impact and the restrictions which has come as a result of this COVID has really denied those people the opportunity to come for medical care, and has made it very expensive for them, because in some cases, some patients have had to hire flights to fly into India to access these services. I want to thank the government of India, because right now we are working on the air bubble initiative, which would help and facilitate the flying between Kenya and India a little bit more easier. And this would facilitate more Kenyans to travel to India for medical services. And so I would want to again thank all of you for that. As you may all be aware, as a government in Kenya, healthcare is one of our key focus. We have 4 pillars now, as put up across by our government through the president, that apart from housing, food security, manufacturing, healthcare is one of the key focus which our government is handling at this point in time. And here we want to get affordable universal healthcare. And to afford that, India is a natural ally. And the reason why I say India is a natural ally is that it is more practical to collaborate with India because of the manufacturing capacity of India of most of the medical equipment required to bring down the cost of healthcare in our country. And so the more we exhibit and show what India can offer in the medical world, the more the business, the private business sector in Kenya can see that the cost of health can be reduced by accessing some of the products being manufactured in India. And so I'm encouraging the partnership. I'm also encouraging the Indian entrepreneur not only to focus on exporting these products to Kenya, but equally to focus on undertaking partnership and manufacturing the same products down in Kenya. And when we manufacture in Kenya, you will not be serving that market of Kenya, but you will be serving a regional market, East Africa and Central and Southern Africa. And so from where I sit, I would want to encourage both entrepreneurs between Kenya and India to work together and build some partnership so that they can start investing in the healthcare manufacturing in Kenya. So before I conclude, I would wish just to give you a little bit of some of the statistics to show the potential existing in Kenya in this area of healthcare. Kenya, in the year 2018, imported a number of assorted healthcare equipment. And I would want you to see curiously where India lies as far as some of these imports are concerned. And it shows you that India has some work to do in terms of improving the relationship between Kenya and India as far as healthcare is concerned. For medical services, the total imports was $60 million, $60.2 million. And India's contribution was $5.98 million. In the medical furniture, we are talking of $7.3 million imported in Kenya, but India contributed $325,000 million. Wound care products, 10 million. Contribution by that which came from India is 407. Running down, let's see, like X-ray equipment was 43.7 million imported in Kenya, but the what came from India was $659,000. Breathing appliances, which applies to the situation we are in now, $1.1 million was imported, and only 31 million came from India. Laboratory reagents, 55.9 million was imported, and 1.6 million came from India. In summary, 10% of all the imports to Kenya actually came from India. And this provides a clear opportunity for the Indian entrepreneur to work more closely with the Kenyan health sector, so that we can improve some of these figures. That is part of my work here to ensure that the trade between India and Kenya really grows. And this is one area where I'm seeing a lot of opportunity for the Indian entrepreneur to work with the Kenyan businessman to see how to build up and increase the trade volume in the area of healthcare. And so I would want to thank all of you and to say that there is a great deal of opportunity in Kenya in the area of healthcare. And it is natural, India is a natural ally of Kenya. There is no much bureaucracy. The countries have put in place all the infrastructure in place in terms of legal frameworks, in terms of collaboration frameworks. We have ready frameworks of letters of credit between Kenya and India. And therefore, it is the responsibility of the business community to really work together and exploit on the working relationship and the bilateral relationship, which is at its all-time high now between Kenya and India, so that we can improve our health systems. And Kenya is going to benefit a lot from the Indian system to see that we also build capacity in our country, especially in the training of doctors, and also in equipping our hospitals to ensure that we improve our health provision for the people of Kenya. And so I want to thank you once again, the organizers of this webinar, and everybody else. I don't know whether there'll be questions, because I would want to also request to take leave almost immediately, because I'm rushing for another meeting. Thank you very much.
Sir, we'll come back to you with questions, as you have already suggested that you want to leave for another meeting. So I will come back to you with the questions and you can reply, your office can reply later on.
Right.
Yeah. Thank you so much, sir. Thank you.
Thank you so much. I hope you will allow me to seek leave.
Right, sir. No problem. Yeah. Thank you.
Thank you, sir. Thank you very much. Your words were very motivational. You highlighted the opportunities for establishing and furthering the bilateral business relationships between India and Kenya in the healthcare sector. Thank you for ensuring support and help to Indian entrepreneurs in establishing their businesses in Kenya. We look forward to benefit from your ever helping office. Thank you very much. Thank you.
Thank you and welcome.
So friends, now we have with us Mr. Safari Kiti, the National Executive Chairman of the Association of Kenya Medical Laboratory Scientific Officers. Mr. Kiti has served as a sub-country medical laboratory coordinator, a lecturer at a private medical training college known as the Outspan Medical College in Nyeri. He has a bachelor's degree in medical laboratory sciences and has served on various positions in the association and is a known advocate of absolute professionalism in Kenya. May I request Mr. Safari Kiti, the National Executive Chairman of Association of Kenya Medical Laboratory Scientific Officers, for his address, please. Mr. Kiti, back office, can you please unmute Mr. Kiti, please?
Dharmendra, I think he has got some connection issue because
He was there?
Yeah, he was just there before a minute. Now I cannot see him.
Yeah. Chalo, let me go to the next
Please.
speaker, and then we'll take Mr. Kiti later.
Right, fine.
Fine. Considered to be one of the very tall leaders of the world today, Mr. Narendra Modi, Honorable Prime Minister of India, introduced the Ayushman Bharat, the Pradhan Mantri Jan Arogya Yojana, or the Prime Minister's Public Health Scheme, a very ambitious initiative with a whooping government spend on improving public health infrastructure and providing affordable healthcare treatment to all citizens of the country. We are happy that we have with us Dr. J.L. Meena, the Joint Director of Ayushman Bharat Scheme of the National Health Authority Government of India, for the keynote address today. Dr. Meena has been working in the field of quality healthcare since 2002 and has a wide experience of working from the bottommost grassroots level primary healthcare centers in India to the top level Johns Hopkins University, USA. He is credited with introducing quality certifications in hospitals and has immensely contributed in preparing quality standards for various kinds of organizations in the healthcare sector in India. He created history by getting a number of government facilities accredited under these quality standards during his tenures at various locations at different levels, and has been honored with several special awards in his career. He contributes as an expert on numerous government committees on quality assurance and standards. May I invite Dr. J.L. Meena to give his keynote address, please. Dr. J.L. Meena, back office requesting you to kindly unmute Dr. Meena, please.
Yeah, thank you, Joshi sir and Pandya sir and all organization for this excellent events. I think this is very important events, especially for the safety of the healthcare workers. And today's my main lecture on the infection control practices. When we say for the infection control measure, I think so the prevention and control of the infection is the responsibility of each and every healthcare providers, because each and every healthcare provider is responsible for the infection control practices. And that's why in the developing the hospital infection control program is very necessary to prevent the infection. If you see the infection control practices in the hospitals, the first is important is the standard precautions. We maintain the standard precautions. The second important thing is the safe injection practices. The third important thing is the sterilization and disinfection practices. The fourth is the biomedical waste management, which is also a crucial role for the infection control practices. Third and fifth is the healthcare worker safety. Our main important is the healthcare worker safety as well as our patient and relative safety. The prevention of the healthcare associated infection is also main role for the infection control practices. And last but not least, the safe infusions, it may be IV or ventilation, is also very important things. And this is the key role of the infection control in the hospitals. The infection control program, which contain the infection control manuals. So first, your hospital should be prepared the infection control manuals, which contain the standard additional precautions and the standard operation procedures. The important thing is the training, and trainings. The training to our healthcare providers, first you the need-based assessments for the trainings to the doctors, to the nursing staff, to the housekeeping staff, to the securities, and the protection of the healthcare worker is very important role for the infection control programs. The surveillance activity and incident monitoring is also important role for the infection control programs practices. And aseptic technique, use the aseptic technique during the injection practices. Isolation of the patient is very important. Key role, especially during the pandemic situations. Use of the single use of the devices and reprocessing of the instrument equipment is also very important role for the infection control programs. The develop the antimicrobial steroids and outbreak investigations, the proper biomedical waste management and environment management practice include the supportive services like the management of the food and linen management also. When we say for the infection control program, I think infection control programs need two levels, especially as the one is the infection control committees, another is the infection control teams. The infection control team is the routine teams, which is daily monitoring, and infection control committee is the high level committees, which is just a advisory body for the hospital to prevent the infection control practices. The role of the infection control committee is very crucial for the prevent infections. The first role is the plan, how you plan for infection control practices, the review and approve the plan for the infection control practices, the review, approve the infection control policies, the role of the infection control committee, support the infection control team, and direct resource to address the problems as the identifications, to ensure the availability of the appropriate supplies, and the review the epidemiological surveillance data and identify area of the interventions for the infection control practices. Our infection control committees also role for the improve the practices, because when we say for the quality is the endless process and it's a continuous improvement process. And that's why improved practices is also key role for the infection control committee. The training is also very important role. Training, before you give the trainings, you identify the need-based assessment of the trainings, what training need to the doctors, what training need to the nursing staff, what training need to the housekeeping staff. So accordingly, you give the trainings and training and trainings. It's a very good practices for the improvements. The review the risk management. When you review the risk management, it's also very important for the key role for the infection control practices and outbreak investigations. You root cause analysis and then CAPA you do for the infection control practices. The community and corporate, the other committees also, like the antibiotic committee, occupational hazard committee, and quality assurance committees. The infection control team is the daily monitoring team, which includes doctors, maybe infection control nurses and microbiologists, and the infection control team is also responsible for the day-to-day running of the infection control practices. And a daily round is also necessary by the infection control team. Which is the high risk area where the infection is more. First is the operation theater is very high risk area. All the intensive care units, ICU, hemodialysis unit, HDU, post-operative ward, interventional radiologies, blood bank, CSSD, TSSU, dialysis, burn unit, delivery room, endoscopy units, isolation units, and procedure rooms. And nowadays the pandemic situation is there. So where ward of the COVID-19 is also very high risk area. The high risk procedure is also like the angioplasty, angiography, blood transfusion reactions, bone marrow biopsy, dialysis, deliveries, endoscopy, surgery, and ultrasound guide biopsies. They are the high risk procedures where the infection control practices is required more. The standard precautions like the hand hygiene, I think it's very important things. If you prevent more than 85% infections due to the proper hand washing practices, use of the gloves is also very important for the standard precautions to prevent the infections. The use of the gown, use of the mask, eye protection or face shields, and safe injection practices is also very important role for the infection control practices. Clean your hand. When you clean through normal hand, you just see that your hand is clean. But when you see through the fluorescence, your some part of the area is contain the microbes. And that's why you need the proper hand washing practices, like the back side, front side, some area which is remaining and not properly cleaned. So the practice of the hand washing is very important. The proper hand washing practices control your 85% infections. Like the hand washing practices, the hand wash, properly hand wash according to the plain soap and waters, the antiseptic hand washings, and with the soap having the antiseptic agents and water, antiseptic hand rub, typically the alcohol base, apply the antiseptic hand rub to all surface of the hand to reduce the microorganisms. The skin flora, the transient flora, the colonized superficial layer, and more immune to the removals, and the residential flora attached to the deeper layer of the more resistance to the removals is the hand hygiene practice is also very important. The 5 moment where the hand washing practices is very important. Like the first is the before touching a patient, second is the before cleaning or aseptic precautions, third is the after body fluid exposure or risk, fourth is the after touching a patient, and fifth is the after touching patients of the surroundings. The step of the proper hand washing practices, as you know, the 6th step is there: palm to palm, each palm over each dorsums, palm to palm figures, 4 back of the figures, oppositional palms, and rotate the palms and rotational rubbers. The one is the step of hand washing practices. Another is also very important for the surgical hand washing practices. The 7th step of the surgical hand washing practices, like the removal of the all jewelries, wet your hands and forearms thoroughly, the clean under each figments with the sticks or brush, hold your hand rubs above elbow levels and apply antiseptic in the circular motions, fingertips to elbow, repeat for the second hand and continue in this way to the 3 to 4 minutes. The 5th steps, hold your hands above elbow and rinse the fingertip first and each arm separately. The 6th step, use the sterile towels, dry your arms from the fingertip to elbow and use different side of the towels on each arm and keep hand above the wrist levels. Do not touch anything, put on sterile gloves. So step of the surgical hand washing is also very important before you proceed to the surgical hand washings. And that's why the hand hygiene is the simplest, most effective measure for prevent hospital acquired infection. And as you know, the 85% infection is prevent due to the proper hand washing practices. And that's why we need proper hand washing practices according to the properly steps. The second important part is the injection safety for the risk. 1 needle, 1 syringe, and only 1 time. It's a very important role to prevent the infection, injection safeties. The magnitude of unsafe injection, why it's happened? The 1/3 carry out potential risk of the transmission of the bloodborne virus. If your unsafe injection practices is there, you infected through hepatitis B, hepatitis others, and other bloodborne viruses. Unsafe injections due to the faulty technique was observed in 53.1%. Faulty technique, it's also very important key role for the unsafe injections. That together the 2 factors at the country level made nearly 2/3 of the injection is unsafe. And that's why what is safe injection practices? Does not harm the recipient, does not expose the healthcare workers or to any risk, and does not result the waste dangerous to the communities. It's the safe injection practices. Like the reuse of the equipments during the unsafe collection, unsafe disposals. So they are the main important for the safe injection practices. How to make injection safety to the patient. Now important is the 1 syringe, 1 needle, and 1 times. The use of the correct gauge and length of the needle required for the injections. Use correct site depending on the volume and age of the patients for delivering the injection. Use correct angle of the insertion of the needle depending on the route of the administration. Check expiry date of the drug and vaccine before using them on the patients, and make sure that the vial or ampoules contain the right drug in the appropriate strength and dose for the patients. And proper storage of the drugs is very important role for the safe injection practices. How you make to injection safe to healthcare professionals? The avoid needle stick injury. We need smart, do not recap, rebend, remove, transport, or reuse needles. Use needle stick injury prevention equipment is very important. Ensure that all healthcare providers in the health facility are immunized with 3 doses of the hepatitis B vaccines, and train all healthcare workers in the awareness of the needle stick injury. Post-exposure prophylaxis should be mandatory and handed to the hospital in case of the NSI. The how to make injections safe to the community. Hazardous needles waste management need to be secured. This is possible by the bring the awareness among the healthcare workers, communities about the potential hazard of the SARP waste, minimize the segregation and decontaminations and disinfections the hazardous waste, use the SARP containers that prevent injury to the healthcare workers, destroy user items to prevent their reuse. And the third most important is the cleaning of the disinfection and sterilizations. As you like, the definition of the sterilization describes a process that destroys or eliminates all form of the microbial lives and is carried out in the healthcare facility by the physical or chemical method, stream under the pressures, dry heat, ethose gas, hydrogen peroxide gas, plasma, and liquid chemicals are the principal sterilization that is used in the healthcare facilities. The disinfection is described as the process that eliminated many of all the pathogenic microorganisms except bacterial spores and inanimate objects in healthcare settings, object usually for the disinfection, while liquid chemicals or wet pasteurizations. The high-level disinfection is required and defines the complete examination of all microorganisms in or on the instrument, except for the small number of the bacterial spores. For FDA definition of the high-level disinfection is a sterilant use of the shorter content time to achieve the 6-10 kilo of an appropriate mycobacterium species. The cleaning is the removal of the visual soils, example of the organic or inorganic materials from the objective and surface, and normally in accompanied manually or mechanism using water with detergent or enzyme procedures. The decontaminations remove the pathogens or microorganisms from the object so that are safe to handle use of the discarded. The germicide is an agent that can kill microorganisms, particularly the pathogenic organism, or antiseptic are germicide applied to the living tissue and skins. The disinfectants are antimicrobial applied only to eliminate the object. So disinfection and sterilization practice is very important role for the infection control practices in your hospitals. Split of the classification like the critical and semi-critical and non-criticals. The recommended practice, like if your contaminated device is there, first you clean, then rinse or flush, then dry, then pack, then disinfection or sterile, and after that monitoring properly. And this is the safe device, no infections is very important role for the recommendation of the practices. How the instrument cleaning process. The stage first is the soak and wipe with the damp cloth at point of use to prevent drying or boil soils on the instrument. The second step is the ultrasonic washers with the enzyme detergent or complex instrument or at a sink, or the automatically washer with the enzymatic detergents is the second step. The third step, the rinse with a large amount of the water. The fourth step, the soak in the high level disinfectants like the gold dry or semi-critical items, or the dry and pack for the stem or EO for the critical items, or store of the future use of the non-critical items. And the fifth step, rinse with the sterile or ultraclinic waters. Use of the equipments control. The Biomedical test negative is there, Biomedical test positive. You see the Biomedical test also for control of infection control practices. The exposure controls, the external chemical indicator as well as the internal chemical indicators. The use of the outside of the each package unless the internal chemical indicator is visible. If not, change, don't use the package. It's very important things for control the infection control practices. The load control of the biological indicators. Biological indicators weekly to every load recommendations as for the daily. Biological indicators in every load that contain an implementable device. Quarantine units like the VI units of the negatives. Biological indicators is every load for the ETOs is also used. The important role for the infection control practices is the antibiotic policies. So your hospital should be prepared proper antibiotic policy. And that's why the antibiotic committee is requirement, antibiotic resistance, antibioma or antibiograms also needed, and adherence to the antibiotic policies. Same is the important thing to the antibiotic programs like the leadership, the commitment, the committee is required, the accountability, the single leader responsible for the program, the drug expertise like the pharmacist is also required in the antibiotic policies. The action, at least one recommended action such as the antibiotic times out after the 48 hours, and tracking, monitoring the antibiotic prescription and resistant patterns, and the reporting of the antibiotic use and resistance to the doctors, nurse, and relevant staff, and education the clinicians about the resistance and optimal prescriptions. And it's very important by the antibiotics policy and infection control committees. Laundry and linen management is also key role for the infection control practices. Some hospitals have the automated mechanism, laundries, washing mechanism, and tumble dryer and calendar mechanism. Solid linen, like the all linen that is contaminated with the blood, etc. Other body fluids in place in the yellow laundry bags and clean after the disinfections. Same for the clean linen, the covered linen card used to transport clean linen to the ward and unit and stored in the closed cupboards for prevent infections. The kitchen is also very important role for the infection control practices. The all food handlers should undergo regular medical examinations like the blood test, stool examination, urine examinations, and also immunized with the hepatitis B, typhoid vaccine, and tetanus toxoid, and also examination of the nail and hairs. The staff trained on the kitchen sanitation and safe handle of the food items and guidelines are provided. The appropriate post-prophylaxis PPE provided and checklist for the PPE maintained at the cafeteria is also very important roles. Engineering control is very important role for the infection control practices, especially in the high risk area, like in the operation theater, ICU, HDU. And the temperature should be maintained at the 21 plus minus 3 degrees and inside the OT in all times. The humidity, related humidity between the 40 to 60%. Air exchange per hour, like the 30 air exchange per hours. The fresh air is component of the air exchange in 14 air exchange out of the totals. And HEPA filter instrument, the major OTs, and air container at entrance of the MICU, OT, post-operative, onco post-operatives, and other high-risk areas. The biosafety cabinet for preparation of the cytotoxic drugs is very important role. And over the hand, tank schedules, formulation of the water filter services, and water testing every 3 months scheduled properly. The housekeeping staff is also the disinfection and cleanliness of the solution used, toilet cleaning checklist, cleaning protocols, pest control, spill management kit is also important, mercury spillage kit, cytotoxic drugs, and food blood spillage kits. Surveillance activity before you continuously, because when we say for the quality is the continuous endless process, and that's why the surveillance activity is very important role for prevent infection or reduce the infection. The surveillance of the healthcare associated infection like the central line associated bloodstream infections, the catheter associated urinary tract infections, the ventilator associated pneumonia, the surgical site infection pneumonia, the wet sores, and the phlebitis, and the hand hygiene compliance is very important for the doctors, for the nursing staff, for the housekeeping staff, the monitoring of the equipments for the sterilization and disinfections, the biomedical waste practices and disposals, and the surveillance of the healthcare worker safety like the needle stick injury and blood food, body fluid exposure to the healthcare workers, and periodic microbiological data for the lab to be evaluated properly. The biomedical waste management, when we say for the biomedical waste management, I think segregation is the important and key role for the proper biomedical waste management. And segregation is the role of the all healthcare workers. At the site of the segregation is very important role. The authorizations through the pollution control board, the state pollution control board, or the central pollution control board, the segregation, collection, and disposal from the common biomedical waste facilities, the annual return and other reports, and the visit to the vendor sites like the visit to the common biomedical waste facilities and use of the personal protective equipments also for the proper management of the biomedical waste management. The spill management kit, you should have the spill management kit and give the training to all healthcare workers. Other measures like the notifiable disease, the IDSP form and formats, use of the PPE, isolation and barrier nursing, and the pre and post exposure prophylaxis practices and outbreak management practices, the regular training on the infection control practices and budgeting for the infection control committees and infection control practices is also very important role for the prevent infections. I think thank you very much and thanks to all organizations to give this opportunities. Thank you very much.
Thank you very much, Mr. Meena, for your very informative presentation on infection control. It was a very critical aspect in the healthcare sector at present. There is a lot to be learned from you, and we are fortunate we have people like you in the government framework who push change and make things better for the benefit of people at large. Thank you very much for your presentation. Thank you.
Thank you very much. Thanks a lot.
We missed out on Mr. Safari earlier, and so now he is rejoined. And once again, I welcome Mr. Safari Kiti. As you know, he is the National Executive Chairman of the Association of Kenya Medical Laboratory Scientific Officers, and has served as a sub-county medical laboratory coordinator, a lecturer at a private medical training college, and has a bachelor's degree in medical laboratory sciences. And he is a great advocate of professionalism in Kenya. May I request Mr. Safari Kiti to give his address, please. Back office requesting you to please unmute Mr. Kiti, please.
Thank you so much, Mr. Joshi. It's a pleasure to be here. I hope I'm audible enough. My name is Safari Kiti, as has been introduced. I'm the National Executive Chairman of the Association of Kenya Medical Laboratory Scientific Officers. That is the laboratory association in Kenya that usually ensures welfare or advocates for the welfare of medical laboratory scientists in the country. I have a small presentation just to give highlights on the role the medical laboratory scientists are playing or should play in relation to the COVID-19 pandemic. Thank you so much, admin, for bringing in my presentation. So that is the topic I'm going to present on, the role of medical laboratory officers in COVID-19 testing. Next. The medical laboratory scientists in Kenya have a multiple number of roles that they usually play in COVID-19 testing. However, I will zero in on 4 roles. The first role is specimen collection. The second is infection prevention and control. The third role is laboratory testing, which is the role that I will dwell much on. And then I will highlight the final role as information management as part of the roles the medical laboratory scientists play in COVID-19 testing. Next. So I'll talk about specimen collection, and I'll just give this one as a summary. The medical laboratory scientists in Kenya since the onset of the pandemic in March 2020, they have been trained and have been capacitated to be able to collect specimens that are being used for diagnosis. The main specimen that has always been collected is the nasopharyngeal swabs, and the medical laboratory scientists have been going to the field, doing contact tracing and collecting nasopharyngeal swabs. And then we also have the oropharyngeal swabs. Actually, the Kenyan system is using a combination of the two, all of them collected and put together in one viral transport media tube, and then they are transported to the testing laboratories. Also, blood samples that are usually collected. When I come to laboratory testing, I will talk about different specimens that are supposed to be done, especially when monitoring the clients that have tested positive, especially things like the dimers, the urea electrolytes, and all that. So blood specimens are also collected. And then the urine samples, because I believe, and I will, when it comes to diagnosis, about the detection of the virus, the COVID-19 virus in urine samples. So these are some of the samples that the laboratory officers are involved in collection. Next. On infection prevention and control, I'll just also do a quick summary that with infection prevention and control, the laboratory scientists are mainly involved in terms of personal protection and waste management. And in personal protection, we are talking about the personal protective equipment, and the PPEs that are involved include the N95 masks, which they must put on when they are donning, and the coveralls, a full set of the PPE that is required for collection of specimens for COVID-19, which has been made available in almost all the settings where the medical laboratory scientists do collect specimens. Then we have issues of hand sanitization and disinfection, which is usually applicable for the officers or the scientists who are going to collect specimens to ensure that they are protected themselves and also they protect the client. Then we have waste management, all the waste that they will generate while collecting specimens for the purposes of diagnosis, and even the waste they will generate while doing the actual testing is handled in a manner that it is segregated upon generation, and it is usually segregated into the color-coded waste bins, and then mainly this waste is usually segregated in the red colored waste bin because it is highly infectious, and then the disposal process is undertaken immediately thereafter. So these are the areas on infection prevention and control where the laboratory scientists in Kenya are involved. Next. Now we will go to laboratory testing, which, as I said, I'll go into great details on this. And before we go to laboratory testing, I will just highlight a few basics, which form the basis for which tests to be done. In order, there are those tests for diagnosis and there are those tests for monitoring to ensure that the clients who are on isolation are getting the proper monitoring and diagnosis. Next. So I will talk about the pathophysiological changes of COVID-19 that usually take place for the uninfected individual, for the moderate COVID-19, and for the severe COVID-19. So you realize that for the uninfected individual, the pulmonary epithelium usually the epithelial cells usually look very normal, as you can see on the slide. And then we have the circulation of the CD4 T cells and the CD8 T cells. And most of the times, these uninfected people will never have any kind of symptoms. That is the normal picture when when an individual is not infected. And when an individual is infected, but at a moderate rate, we have the epithelial cells. As you can see, the third cell and the fifth cell, you can see how they are damaged because of the infection and infestation by the SARS-CoV-2. So you'll realize that we will have macrophages. When you do a peripheral blood film, you can be able to see a lot of macrophages. When you do the immunochemistry, you'll also be able to see the TNF. So the cytokine levels, when you do cytokine levels for such class, you find that the levels are quite increased. Then we have the CD4 T cells. You will find that they will be expressed. So you can even do CD4 T cell count and you will be able to detect quite a number of them. Then at this point, the client develops some symptoms like fever, cough, general malaise, some fatigue, and then there will be some myalgia that will be experienced. For the interleukin 6 levels will be raised. Then there will be reduced lymphocytes, the CD4 cells, and the CD8 T cells. For severely infected clients who have severe COVID-19, you realize that the pulmonary epithelium or the epithelial cells along the pulmonary region will mainly be abnormal. Because they have been infected and they will be completely damaged. When you do cytokine levels, there will be a cytokine storm. There will be a highly increased cytokine levels, then CD4 T cells will really be reduced to lower, very lower levels. And then the patient will develop some fever, cough, fatigue, myalgia, dyspnea, and then the respiratory failure is likely also to develop. When you do interleukin 6, you'll find the levels of IL-6 are very high. Then when you do the LDH, D-dimers, procalcitonin, CRP, ferritin, soluble IL-2R, and IL-10, and TNF alpha, all those will be increased. The reduced levels for lymphocytes, the CD4 cells, CD4 T cells and CD8 T cells will be reduced. Then there will also be reduced IFN, and then the NK cells will also be reduced. However, white blood cells will be increased. Next. Next. So when we look at the pathophysiological changes, especially we will find the multi-organ damages, as I mentioned, because of the viral attacking, and then there will be the inflammatory storm taking place, and there will be an underlying disease. The lungs will be filled with mucin fluid, white blood cells, and dead epithelial cells. Then the heart, there will be damaging to the myocardium. Then hemopoietic system will get T lymphocyte apoptosis, and then there will be depletion and platelet degradation and consumption. For the liver, when you do liver function, you'll find that there will be liver function impairment. And then for the kidney, there will be damage to the glomerulus, mainly noted through proteinuria and hematuria, and then kidney function failure. At some point, the brain, there will be some encephalitis. The patient may develop into a coma, stroke, and maybe some client may develop epilepsy. Then the blood vessels damage to the endothelial cells, causing coagulation disorders. Then in the gastrointestinal system, we'll find that such clients may develop nausea. Some may end up even vomiting and developing diarrhea. Then the eyes may develop some conjunctivitis, which may be seen clearly through the eyes developing some pink color, and then we will also get some epiphora. That is mainly the eyes are producing tears. Then skin, we may be having some skin rash and peeling of the skin, which we call desquamation. Next. So the impact of the COVID-19 on the different organs and the laboratory diagnosis, we are looking at the hematologic and hematopoietic system. And this, I'm bringing it up because most laboratory scientists have been dwelling on the diagnosis through PCR, but I want to show to bring a picture that mainly there are other areas when we are monitoring the infected clients we need to look at. For example, the total WBC. When you do a hematologic get a hematologic picture, you realize that the total WBC can be normal or decreased at an early stage of infection, but the WBC will increase with concomitant actions of bacteria and multiple organ failure. Then for the neutrophils, when we do the differentiated cell count, when the neutrophil count and percentage can be normal or elevated. Morphology will show some abundant and coagulated granules, coagulation of the granules in the nucleolus and the cytoplasm, indicating responses from severe virus and bacterial infection as well. Then for the lymphocytes, we may get lymphocytopenia and eosinopenia, which are often observed with increased neutrophil or lymphocyte ratio. Then the reduction of lymphocytes and elevated NLR will represent a severe condition of the patient. Toxicity, mainly due to the virus to the lymphocytes, leading to apoptosis and consumption of cells, are mainly the cause. Then we may have alteration of the next. Next, please. So generally, we will realize that when you also you can also do the APPT and PT, which will be up, and you can also even do the dimers, where you will there will be elongation of the PT, the thrombin time, an increase or an elongation of the activated partial thromboplastin time APT, which mainly presents or can do AL. There will be an abnormal ALT, aspartic aminotransferase. We will find that it will also be increased. It will be abnormal. Total bilirubin, lactate, the LDH, and the gamma GT, alkaline phosphatase, all those will be seen elevated in mainly severely ill patients, and it's mainly cytokine and the virus attack to the liver. Then the renal function, creatinine, serum creatinine, and serum urea whenever there is severe disease. And then we may also get increased angiotensin 2, which can be seen in some severe cases. Next. For the heart, there will be elevation of the LDH, CK, myoglobin, and the cardiac troponin may also be seen elevated in severe patients. For the cytokines, you can see some elevation of the CRP, which is more, but procalcitonin is usually normal. Get elevated serum amyloid, which mainly will be an indicator of poor prognosis. Next. Sorry for the poor connection. Now, the molecular diagnosis, which is the commonly used form of diagnosis in Kenya, will mainly identify the virus nucleotides. And the etiology will mainly be the use of real-time PCR, which is the commonly used in the country. And as I mentioned, majority of the specimens in Kenya being collected is a combination of the nasopharyngeal swab and the oropharyngeal swab, which are combined in one virus transport media for testing. We can also be able to demonstrate the nucleotides of this virus in sputum and in blood and even in stool can be detected. We have the next generation sequencing, which can also be done to confirm diagnosis. With serology, this is still a debate, although in the country, some serological diagnosis is being applied in some sectors, although it is still a great debate. We have serum antibodies which can be detected in patients' blood. Mainly the IgM is usually positive after 3 to 5 days of the onset. IgG is usually detected in 7 days, and it will be stronger in recovering in the recovering period. Next. So this is just a highlight of our asymptomatic and subclinical infection cases of COVID-19, where infected person who does not have clinical manifestations but is secreting or is shedding the virus will become an infectious source. And this type of infection can be diagnosed by laboratory techniques such as the virus nucleotide detection, the real-time PCR, which is the reason as to why in Kenya we are mainly using the real-time PCR. However, the capability of COVID-19 transmission from infected person who is in the incubation period, mainly asymptomatic infection, is still unclear and lacking of scientific evidence. A lot of researches are being done, but the risk of this type is very important for the final elimination of the pandemic. Next. So I'm through with testing. I think I will go to information management. The laboratory testing, right from the specimen collection all the way to the release of the results, mainly information management involved the line listing of the contacts or the suspects. And then when the testing is done, there is the results recording and release of the results. This one they must manage through either a laboratory information management system or any other type of for the Kenyans system, majority of health through the Cabinet Secretary for Health. And this data, they usually manage all the testing laboratories usually consolidate, transmit it to the relevant authorities for release. Then there is also the records archiving, right from the initial tests to the testing that will be done today. All those records are usually archived for purposes of retrieval whenever need there is. The laboratory scientists also are involved in research, and I believe we have a few publications that have been developed since between March and now, and this is an ongoing process. So virtually, that is what the laboratory officers are doing in terms of diagnosis. Next. So thank you so much. I will invite comments and questions because that brings me to the end of the presentation. Thank you.
Thank you very much, Mr. Kiti. You highlighted some very important and relevant aspects of the impact of COVID virus on different organs of the body and the role of medical laboratory officers in the healthcare sector. Along with the doctors, we salute all such healthcare professionals for their services during the pandemic and wish the God Almighty give you great strength for not being affected yourselves and keep serving the common man. We'll take questions later. I would request anyone who has questions to kindly pose your questions on the platform that you are on, and we'll take all the questions later. We will now move on to our next speaker, who's Dr. Karnav Patel. Dr. Karnav Patel is a dentist. He did his dental graduation and was awarded as the best outgoing student during those days. He completed his master's in oral maxillofacial surgery and has been practicing at the Apollo Hospital, Ahmedabad, Gujarat, in the head and neck cancer department as a consultant, working mainly on advanced surgeries which involve microvascular surgery as well as rehabilitation aimed at giving excellent functional results. He is also the founder of 2 startups, HashiCare and Salvo India. He is also the technical advisor to mask manufacturing companies as well as some startups. Dr. Karnav Patel, please. Back office, will you please unmute Dr. Karnav Patel?
Thank you so much for the introduction. Am I audible enough?
Yes, Karnav bhai.
Yeah, thank you.
You need to unmute.
Yeah, I joined through my phone also. Am I audible now?
Yeah, you are.
So first of all, I would like to thank everyone, the organizing team. Special thanks to Pandya sir for inviting me for the lecture. And we had a great discussion in the past hour. And we have heard about the technical aspects in the laboratory from Safari sir. We have heard from Meena sir also regarding the sterilization protocols. I'll be talking more about the clinical aspects. So I'm Dr. Pranav Patel and I work in head and neck oncology. Let us not waste time and get into the technicalities. So healthcare professionals and patients may have different risk profiles, which may include the practice environment, the geographical location of the practitioner, and the scope of practice, and the personal circumstances. So there is no one-size-fits-all approach for the whole profession. So we have various specialties, and we have different approaches for each specialty. Our approach should be pragmatic about what can be safely and practically achieved in primarily healthcare setting with limited resources what are available. The team may require a risk assessment to ensure their own safety, and vulnerable patients must be suitably protected. We need to continue exercising our professional judgment and weigh the risks of the given condition. Practitioners should note that the mitigations in place for high alert levels have led to increased patient outcomes for patients, safer and more caring and efficient service for patients, and better led practices. It would be encouraged to return these measures to a new normal because these measures have helped in reducing the infection rates overall. So right now, what should be our priority? It is to deliver safe clinical care to patients, ensuring that the personal risks to the staff are reduced by adopting an individualized risk assessment for all the members of the team. This risk assessment part is most important because this leads to prevention of the spread of infections from individuals to healthcare professionals as well as vice versa. Good evidence, risk assessment, consideration of patient needs, and the overall and return to routine practice are built. So there is something known as hierarchy of controls given by the National Institute of Occupational Safety and Health. So the idea behind this hierarchy is that the control methods at the top of the graph are potentially more effective and protective than those at the bottom. Taking this chart into consideration, elimination is the first thing which can be done. But in case of infection, it is practically not possible. So next is substitution or replacement of the hazard. Even that is not possible in case of COVID-19 or hepatitis or HIV or any other infection for that matter. Engineering controls like isolate the people from the hazard, which has been practically done throughout the world. Administrative controls like lockdown have been placed throughout the world to prevent the spread of infections. And the last and least effective resort, which has to be taken care, is the personal protective equipment, which are worn by the healthcare officials as well as other people to protect themselves. Coming to the clinical part, communication and consent. Most important, essential things to be taken care of. Significant changes to the way healthcare is delivered has taken place in the past few months. Effective and meaningful communication is necessary so that the service is well received. Errors that occur often are results of poor systems and processes. A lot need to be redesigned to make the process easier, and cross-checking has to be done to reduce the errors. For each, various publications and various literatures shows the division of treatment into 5 phases, like pre-appointment, pre-treatment, during treatment, after treatment, and management tasks. These phases might vary depending on the practice and the department which is being practiced. So coming to the pre-appointment part, communication is necessary in these days ahead of the visit. A digital pre-appointment pack can be made. Administrative tasks has to be undertaken ahead of the visit if possible. Patient questionnaire depending on the particular department has to be prepared. Medical history and COVID screening if necessary has to be done. Risk assessment and patient preparation information has to be collected. Necessary forms like estimate and consent can be signed before the appointment itself if possible, and the payment methods has to be discussed in advance. Review of technology is utmost necessary. These are the times when we need to use advanced technologies. Support and training should be put in place in clinics and the paramedical staff as well as reception so that they understand the technologies and use them to their advantage. A risk assessment should be considered as a part of the pre-planning. Age, pre-existing health conditions, pregnancy, such things should be taken into consideration as increased mortality rate has been seen in vulnerable patients. Coming to the next part, the pre-treatment part. Communicate arrangements and protocols to the patients in advance. to minimize the contamination by offering like separate storage for bags, hand gel at entrance and exit, minimize waiting times in common areas, remove magazines of coffee bar from the reception as used to be in the earlier days, and adoption of high level of infection control and prevention. Protection of the reception staff by social distancing, appointments tailored in new ways, temperature checks can be done, but they are not as reliable as they were deemed. They are widely educated, but the sensitivity and specificity is still poor, may be appropriate as a part of risk assessment for staff or patients who are feeling unwell. Testing, if deemed necessary, which is of utmost importance. Laboratory testing is the most reliable method. Ongoing training for all the staff is necessary. Try to avoid delays from the patients and make sure that the appointments are in time. Patients should be taken directly into the operating room as quickly as possible following the arrival. The COVID-19 is mainly through three modes: contact, droplets, and airborne. The reception area should be designed to support social distancing, which includes designated seating, clear staff pathways or patient pathways, laminated notices, and floor markings. Now, what should be taken care of during the treatment? Standard operating protocols apply depending on the specialty which is being practiced. There can be aerosol generating procedures, high risk or low risk. There are certain departments where there are no aerosols generated. When there are low risk procedures, a standard PPE kit is sufficient. But in case of high aerosol generating procedures, an N95 mask with visor and gowns would be preferable. When there are high aerosol risk procedures performed, a fallow period would be recommended. What are the standard precautions to be taken care of? Hand hygiene, which was specifically mentioned by Meena sir in his presentation, PPEs, respiratory hygiene, staff safety, safe injection practices, sterile instrumentation, and clean and disinfection of surfaces. A proper stratification should be done about how is the type of the procedure, what will be the level of aerosols created, the length of the procedure, and utilization of mitigating factors. Mitigating factors like high volume aspiration. So there is heating, ventilation, and air conditioning system used, like at least 6 air changes per hour is the minimum requirement, and it would be ideal if it is more than 12. HEPA filters can be used, ultraviolet light is being used, barriers like plastic sheets or room dividers are definitely used, very friendly, user friendly. Now coming to the protective equipments and instruments, the PPE kit. So it depends on the procedure which we are performing, the face shield, goggles, mask selection. These are the important aspects which need to be taken into consideration. Coming to mask, which is the most talked about topic these days. So I personally say that the seal of the mask, the peripheral seal or the facial area is much more important than the brand. The fit test is more important, and the basic requirements should be met, like PFE, BFE, breathability, splash resistance, flammability. I won't go in depth into these things because the time won't permit. Eye protection is important with the complete protection of the eye. So as far as the N95 seal check is considered, there are two types of seal checks. One is a positive pressure check and negative pressure check. Fit test, qualitative and quantitative, both are necessary, but which is not practical in hospital environment. It has to be done by the manufacturer. And the replacement, if N95 is not available, other types like R-type or P-type or powered respirators can be used. Coming to the after treatment scenario. So a lot of things has to be done after the treatment or a procedure is over. Standard decontamination procedure should be followed. Paperwork should be avoided. Mask should not be removed in the operating area to protect the other members of the team. All the donning and doffing techniques should be learned in a proper manner and repeated by the staff to avoid any mistakes. The ventilation should be improved. The mitigating factors should be in place. High risk procedures should be taken at the end of the session if possible. And importance should be given to digital clinical records, and a paper record should be avoided if possible. We'll look into the guidelines which have been set by AIIMS Delhi. So in the doffing area, there should be 3 different red bins, separate for goggles and face shield, which has to be immersed in 0.5% sodium hypochlorite for 10 minutes and then wiped. The N95 mask and coveralls should be stored in double bags and handed over twice daily to the authorized staff. And the disposable PPE should be handed over to the authorized collecting staff. The biomedical waste disposals should be as per the existing rules. The color-coded bins or bags or containers should be segregated with double-layered bags. Meena sir had given prime importance to segregation, and even I think that that is utmost important that we segregate the waste properly. Dedicated collection bins should be labeled as COVID-19. The bags or bins or trolleys should be labeled as COVID-19 waste, and maintain the records of generation, segregation, collection, and disposal to make no mistakes. So cleaning the area. So dedicated staff should be wearing PP and following the particular guidelines. Sodium hypochlorite, fresh ones, is highly used disinfectant along with 70% alcohol. Apply the disinfectant to the surfaces using damp cloth and do not use spray pack. And while mopping and all, steady sweeping motion should be used to prevent aerosol generation. Remove the curtains or the fabrics or the quilts for washing at hot water laundry cycle with detergent or bleach at 70 degrees for at least 25 minutes. Discard the cloth or absorbent cleaning. Mop head wiping cloth into biohazard bag after cleaning and disinfecting. Each fasten the bags with cable ties. Disinfect the buckets with soaking in 1% hypochlorite solution. So how frequently the cleaning has to be done? So in the high test surface areas, in the clinical areas, every 1 or 2 hourly or 2 to 3 hourly in the COVID-19 suspected areas, and in low touch areas, every 3 to 4 hourly. Terminal disinfection after the patient is discharged or is shifted or expires. All the measures as discussed earlier. After that, the fogging with hydrogen peroxide based disinfection has to be done. It should be done at least for 30 minutes of contact. After the completion of fogging, keep the room closed for 45 minutes for the mist to settle down. Once again, wipe all the surfaces with clean duster. The dilution is given in the chart. So these are some of the pictures. Now coming to the last point, the management tasks. So the protocols should be reviewed regularly and reflect the level of risk. Identify the members of the staff to fulfill the specific duties. Appropriate signage and demarcation for social distancing, as mentioned earlier, should be followed. Risk assessment of the staff is recommended. Appropriate training should be in place so that no problems occur even in case of medical emergencies. The stock should be reviewed, as it has been seen that sometimes there is a deficit of the availability of PPEs or masks. So this has to be reviewed and proper management should be done. Wherever possible, a flow through the work area should be implemented for clear separation of the clinical and non-clinical workspaces. Patients may also present with increased psychological health problems because of the COVID-related anxiety. So that even that should be taken care of. So important consideration which I would like to comment is the risk cannot be eliminated entirely, even in case of COVID or any infection, maybe other infections as well. But we can attempt to mitigate it, drawing on what we have previously discovered as best evidence and what appears to be safe and pragmatic and practical. Thank you.
Thank you very much, Dr. Kanav Patel. Your presentation was really informative and highlighted various important aspects on the topic of safety. Friends, we are moving very fast ahead because we have a B2B at around within around half an hour, and we still have 2 more speakers left out. So my request to the next 2 speakers not to overshoot their time and probably use less time than normal, so that we finish off our session in time. We have with us Mr. Lawrence Swamiti, the National Executive Committee member of the Association of Kenya Medical Laboratory Scientific Officers. He has also been involved in setting up medical laboratory facilities and planning specific exhibitions and conferences, holds a master's in medical laboratory sciences, and has served as a medical laboratory officer in various health institutions in Kenya. May I request Mr. Lawrence Swamiti to give his presentations, please.
Hello.
Yes.
Can you hear me?
Yeah, we can.
Oh, thank you very much. As you have stated, my name is Lawrence Swamiti. I'll be presenting specimen management of COVID samples. Next, please. So there are some questions on what is COVID. Is it related to SARS 2003 virus? See, corona. Next, please. Next slide. Corona.
Can we run the slide, please?
Sorry.
Next slide, please.
It's hanging.
Yeah.
Thank you very much. Now, some question, is it related to 003 SARS virus? Coronavirus family contains 4 strains that affect humans only and are usually mild and self-limiting, and other strains that circulate among animals and can be contracted by humans and cause severe respiratory illness such as 2003 SARS, MERS, and COVID-19. Also, there's a question of whether COVID-19 is a severe respiratory infection, acute respiratory infection. And this is when patients have severe and complicated pneumonia requiring hospitalization. And also cluster could signal beginning of transmissible strain or even pandemic. Also yields important information on circulating strains. Next. The case definition by WHO: 1 patient with severe acute respiratory infection with fever, coughing, and requiring admission to hospital, and with no other etiology that fully explains the clinical presentation, and a history of travel or residence in China during the 14 days prior to symptom onset. Or B, patient with acute respiratory illness and at least one of the following during the 14 days prior to symptoms onset, that is contact with a confirmed or probable cause of COVID-19, worked or attended a health facility where patient with confirmed or probable COVID-19 acute respiratory disease patient were being treated. Next. What is a probable cause or a probable case? A suspect case for whom testing for COVID-19 is inconclusive or is tested positive using panconvirus assays and without laboratory evidence of other respiratory pathogens. A confirmed case is a person with laboratory confirmation of COVID-19 infection, irrespective of clinical signs or symptoms. Next. The sampling criteria: correct sample from a person under investigation that meets the case definition. All patients will have NP or OP swabs corrected. Suspected COVID-19, all patients will have NP or OP swab corrected. Next. Specimen correction for suspected cases. Specimens to be corrected for diagnostic of COVID-19. We have the primary respiratory specimens, that is NP, OP swab in arbitrary patients, and sputum if produced, and or endotracheal aspirate or by lavage in patients with more severe respiratory disease. The best practice is to correct as soon as possible after specimen begin, and ideally within 7 days before antiviral medication is administered. A single negative test does not exclude infection if the clinical index of specimen is high, and repeat sampling and testing preferred with lower respiratory tract specimen and strongly recommended in severe progressive disease. Next, continuation, we have the secondary specimen, blood specimen for serological testing. Paired blood specimens are most useful. Acute specimen within 7 days after symptom onset. Convalescent specimen 2 weeks or more after the specimen. This is additional to the respiratory specimen and can support the identification of the true agent once serological assay is available. So why do we have NP or OP? NP, traditionally, this is the method used for seasonal influenza surveillance. It provides lower yield for novel coronavirus. The OP, or the throat swab, this swab has the highest yield of novel coronavirus. It's not traditionally used for seasonal influenza, but experimentally, the yield has been good. Next. So those are the swabs that we use. the Dragon tripped swabs, flexible for OP, the Lion aluminum shaft for NP. Next. The sampling procedure. Next. For every patient that meets the case definition, fill out the questionnaire, correct the NP swab, and correct the OP swab. Next. The materials needed for correction of NP and OP, we have the gloves, the swabs, with a tongue depressor, sterile scissors, paper towel, biohazard, bags, N95, VTM, permanent. The questionnaire, note, do not use arginate swabs or swabs with chaff as they may inactivate some viruses and inhibit molecular acids. Next. The protocol. Next. Protocol for swabs, record in specimen logbook, label tube with VTM, label data collection form, insert the tube into nostril parallel to the palate and straight back, not upward. If a resistant is met to another nostril, leave in place for 3 to 5 seconds, slowly move swab while slightly rotating it, put tip swab into vial containing VTM, cut swab with scissors disinfected with bleach spray. For the throat swab, next. As stated earlier, it has the highest yield on detecting COVID-19 in suspected cases. Have the patient open his or her mouth wide open. The patient should try to resist gagging and closing the mouth while the swab touches the back of the throat near the tonsil. Next. Continuation. Have the patient open the mouth, secure the showered head on the lap of the patient or the caregiver, hold the tongue down with a tongue depressor, then swab the posterior phalange, not touching the tonsil or nose or the tongue. Patient should resist gagging, closing the mouth as already stated. Place the swab in the same swab, cutting the scissors disinfected with the bleach spray. The documentation, each package with the specimen should include the line list, patient name, patient ID number, specimen type, date corrected, clinical contact name, phone, email, clinical submeter, affiliation phone, relevant clinical information, symptoms, date of symptoms, onset, travel history, travel exposure, for death, primary autopsy report. Next. The 3-layer triple packaging system should be used. The primary container must be watertight. Wrap multiple containers individually to prevent breakage. Everything in the primary container, including transport media, is considered the infectious substance. The secondary packaging, package with suitable cushioning material. Outer packaging, protect contents from outside influences, physical damage while on transit. EIT shipping guidelines should be followed when shipping. Next is a diagram of the specimen packaging. Do not put any patient information on the outer container or secondary container. Biohazard label should be secondary container. Do not put biohazard label on outer container. Next, we have some guidelines, shipping guidelines that can be referred when shipping. The ones on display, the 3 of them can be used. Next. The transport regulations. Transport of fixtures is subject to strict national and international regulations, proper use of packaging materials, proper labeling and notification. If you compliance, it reduces likelihood of damaging packages, it minimizes exposure, improves carriers' efficiency and confidence in packing delivery. Next, continuation of transport regulation subject to regular amendment. Shippers refer to latest insurances of national and international regulations for regulations. International regulations not intended to subside local or national regulations. Where national requirements do not exist, international regulations should be followed. sample processing in the laboratory. The COVID specimen should be handled according to appropriate biosafety practices in order to avoid laboratory-related infections and spread of disease to close contacts. As primary route of infection is through via drops, extreme caution should be exercised to eliminate unguarded production of aerosols. Detailed information about containment facilities, biosafety practice recommended in this document may be found in WHO Laboratory Safety Manual second revised edition on WHO website. Since COVID-19 is a virus, all laboratory practices should be appropriate for work with viral agents, with particular emphasis on potential spread of droplets, air, and or contaminated surfaces and objects. Next. Continuation. No procedure should be undertaken in which there is any doubt about the ability to adequately contain the specimen and prevent the uncontrolled release of the virus. The following precautions are strongly recommended by WHO for work in BSL-2 laboratories with COVID specimens. Any procedure that may generate aerosols should be performed in BSC. Laboratory workers should wear PPE according to the risk of aerosols exposure when performing specific manipulations. Certification of human specimens should be performed using sealed centrifuge lotus or sample cups. Procedure performed outside BSC should be performed in a manner that minimizes the risk of exposure to advent release of the etiologic agent. Next. Work surfaces and equipment should be decontaminated after specific processing. Standard decontamination engines that are effective against lipid envelope viruses should be sufficient. In case where laboratory facilities are marginal, consideration to be given to refer of specimen to suitably equipped reference laboratory for primary diagnostic tests. Before starting the testing of specimen, at least 3 aliquots of the original specimen must be prepared. Next. In conclusion, please consider the time of specimen collection relative to specimen symptom onset and clinical presentation are very important when considering what specimen to collect. Maintain proper infection control when collecting specimens. Use approved collection methods and equipment when collecting specimens. Handle, store, and ship specimens appropriately to the laboratory for analysis. Next. Storage specimen must be kept cool. If transported less than 72 hours, keep at 4 degrees. After 72 hours, keep at -70 or ship on dry ice. Avoid repeated freeze-thaw cycles. Do not use frost-free freezers. Cellar may be stored at 4 degrees for up to 1 week. Long-term storage, -20 degrees in non-frost freeze freezer acceptable. Thank you very much. I welcome any question or comments. Maybe Rita, use the timings. Thank you.
Thank you very much, Mr. Vamiti, for your excellent presentation. We look forward to your support in the coming times. We'll keep interacting on any aspects related to the subject. Thank you very much. I now invite Mr. V.R. Patel, retired Chief Environmental Officer of the Gujarat Pollution Control Board and the CEO at the Veer Enviro Management Consultants, for his speech. Mr. Patel has over 36 years of experience in implementation of various environment acts in the state of Gujarat. He is also he was entrusted with the responsibility of regulatory clearance of consent to establish consolidated consent and authorization, monitoring and sampling under various environmental acts. He was a regional officer and vigilance officer and has contributed immensely in the policy planning of environment management systems for the polluted areas. I request Mr. Patel to give his presentation, please. Back office, can you manage to unmute Mr. Patel and get his presentation?
Thank you. My subject is importance of biomedical waste management. Hello, it is audible?
Yeah, audible.
Okay, fine. So my subject is importance of biomedical waste management. So this is the last point of totally management and clinical and medical things is to be done previously. So please start. Next slide. Next slide, please. So I will first say, what is the biomedical waste? Biomedical waste means any waste which is generated during the diagnosis, treatment, or immunization of human beings or animals, or in research activity, and including category mentioned in Schedule 1 of these rules. What is the need of biomedical waste management and handling? Biomedical waste is not handled in a proper way, is a potent source of diseases like AIDS, tuberculosis, hepatitis, and other bacterial diseases. Nosocomial infections in patients from poor infection control practices and poor waste management. Drugs and syringes which have been disposed of being repacked and sold off to unauthorized buyers. This is really a biggest problem for the not managing the safe biomedical waste. Where does these rules are applied? These rules are applied to all persons who generates, collects, receives, store, transport, treat, dispose, and handle the biomedical waste in any form, and shall not apply, and it will not apply to radioactivity, e-waste, and other municipal solid waste. So this is a purely a waste management concern for the biomedical waste. Now, the provisions next and silent features of these rules. Ministry of Environment and Forest in 1998 has framed the biomedical waste management rules. The Ministry of Environment and Forest has notified on 28th of March 2016 again. Then it was revised in 2018 and also revised in 2019. So continuously Ministry of Environment and Forest and Climate Change, in association with all the technical experts of the entire country, they are doing the dialoguings and getting the views from the all technical persons, all engineers and scientists, and they have framed these rules. I think this is the one of the best engineering and scientifically rule framed in our country. These rules have a silent features. The biomedical waste rules contains 18 rules, 4 schedules, and 5 forms. Biomedical waste categorization, segregation, collection, treatment, and disposal that falls under Schedule 1. Under Schedule 2, standards for the treatment and disposal. Schedule 3 covers authorities and the responsibility. And Schedule 4 covers labels of biomedical waste containers and the bags. There is a Form 1 called for the accident reporting. When any accident occurs, at that time Form 1 shall have to be filled up by the clinical hospitals or the laboratory. Form 2 and 3 are for getting the authorization and for doing the application in the State Pollution Control Board. Form 4 is for the annual reporting, where they have to report annually how much waste they have generated and how much waste they have disposed of through common biomedical waste facilitator. And Form 4 is for the appeal. Next. Management and handling of the biomedical waste. So the responsibility, we have already spoken. Next, please. Next, please. The municipal body, the untreated biomedical waste mixed with other waste. What are the things to be taken care for this? Biomedical waste shall be segregated into a containers or bag at the point of generation in accordance with the Schedule 1. The container shall be labeled according to Schedule 4. The transporter shall transport the biomedical waste from premises to an occupier to any off-site BMW treatment plant facility only with the label as prescribed in Part A of the Schedule 4, along with the necessary information prescribed in Part B. So these all are the technical aspects and the forms and the schedules which I have already mentioned. No untreated biomedical waste or any category shall be kept stored beyond the period of 48 hours. So this is very important rule, that any hospital or clinic cannot store biomedical waste more than 48 hours. And if they have stored, he has to report to the State Pollution Control Board, and State Pollution Control Board will ask the authority, those who are having the facility for the biomedical waste, to act as early as possible. And we have to keep in mind that we should not store more than 48 hours. And we can, State Pollution Control Board, under the provisions they can take the actions against the operator or against the storage people also. Next, please. Next, please. This is the management and handling of biomedical waste. The municipal body of the area shall continue to pick up and transport the segregation non-biomedical solid waste as well as duly treated biomedical waste for disposal at municipal dump sites. So sometimes what happens practically, if we see the local body or the municipal corporations or the hospitals or the management people are doing mistake by the lower people, those who are managing with the biomedical waste. They do not segregate the properly, and they put this waste in the municipal solid waste, so that ultimately from the municipal solid waste container, the waste biomedical, that infectious waste goes to the solid waste dumping site, and where the infections takes place. So this is the very strict provisions under the law. For the transportation also, we have to, next slide please. Next slide. For the transportation in the hospital, we have mentioned here that no personal people doesn't have no protective clothing, overloading of the trolley, excessive spillages of the waste. So such type of precautions we have to take, and we have to manage in closed system with the PPE and all these things. Nowadays, as the COVID pandemic system is in all over the world and especially in our country also, we all are alert how to manage the waste management system. Next, please. Next slide, please. How this waste is generated, waste is segregated. All the waste that includes infectious, office, general, food, construction and chemicals mixed together, collect, transport, dispose of and waste leaving hospitals, infectious, risk and hazards of the chemical. So this is not the right practice. Next slide, please. Next slide. So there should be a proper segregation of biomedical waste. Here, I will show you in yellow, red, blue, and white. This is as per the Schedule 1 of the Biomedical Waste Rule. In Schedule 1, the yellow bins are which attracts the human anatomy waste, which includes human tissues, organs, body parts, fetus below, all the medical pregnancy act, then animal anatomical waste, solid waste, soiled waste, then expired and discarded medicines, chemical waste. So all chemical liquid waste, discarded liners, mattresses, bleeding, contaminated with the blood and body fluids, microbiological and biotechnological and other clinical laboratory waste. These all yellow labeled waste shall be ultimately disposed of, transported and safely disposed of for the incineration purpose. Now we talk about the red labeling. Red labeling includes contaminated waste which is recyclable, which covers waste generated from disposable items such as tubing, bottle, intravenous tubes, sets, catheters, urine bags, syringe without needles and fixed needle syringe, and vacunatories with their needles cut and the gloves. This waste should go to the autoclaving systems as in the waste management site. Now we talk about the blue. Blue color coding is covered normally glassware, broken or discarded and contaminated glass, including medicine, vials, ampoules, except those contaminated with the psychotoxic waste, and metallic body impact. Now we talk about the white waste, white container. Waste sharp, including metals, needles, syringe with fixed needles, needles from the tip cutters and burners. These all should go to the autoclave or dry heat sterilizations, followed by the shredding practices. So these are the color coding specifically mentioned in the biomedical waste. Next slide, please. Next slide, please. Again, the temporary storage within the hospital. This is the color picture, pictorial picture of the how to store the waste in the hospital management. Here again, very attractive point, important point is 48 hours, that we cannot store any waste more than 48 hours, or this is a legal problem to us. Now, next slide, please. Next slide, please. Schedule 1. This I have already explained you about the Schedule 1. What are the things covered under yellow? Human anatomy. Next slide, please. Next. Then red. Next, please.
Please change the slides.
Please change the slides.
Yeah.
Red, this white. So I have already explained you as per the notifications. But this is the some idea so that we can learn. The chemical treatment using 1% hypochlorite solution or any other equivalent chemical reagents. Multilations shreddings must be that so as to prevent the unauthorized reuse. Here again I will tell you, the unauthorized cycles in the hospital at the lower level and in the local body level. These unauthorized people are collecting the waste from the hospitals with the unauthorized way, and they sell it, they clean it and sell it into the market, which is a very much dangerous thing in our society or in our country. So we have to stop these things at any cost, and there is a legal provisions for taking the actions. Nowadays, all the officials of the hospitals, all the ward boys, those who are managing with the waste, they are totally aware. The main thing is that the training of the ward boy, training for the segregation, training for the recycling, training for the proper management of biomedical waste, and the awareness shall be created within the hospitals and the laboratory facilities, so that the lower staff, those who are working directly with the waste, can get aware about these issues. Now we can, next slide please. Next slide. Treatment and disposal. Next. Treatment, next slide please. Treatment and disposal. Biomedical waste shall be treated and disposed in accordance with the Schedule 1 and in compliance with the standards prescribed in Schedule 2. Any persons including an occupier, operator of the biomedical waste treatment facility intended to promote a new technology for treatment of biomedical waste shall approach the central government or central pollution control board for prior approval. Every occupier shall either set up his own biomedical waste treatment equipment prior to commencement of in operations or ensure treatment of biomedical waste through authorized common biomedical waste treatment facility every operator of a common BMW treatment facility shall set up BMW treatment equipments prior to commencement of the operator. Here I will inform you that in accordance with the honorable court orders, there is a criteria that within the range of 70 kilometers, only one operator can work for the biomedical waste management. So within that 75 kilometers of the area, whatever the facilities or whatever the hospitals or the clinical laboratories or bedded hospitals are covered with that respective operators. So, and we have to keep very consciously that use the chlorinated plastic waste of handling of biomedical waste shall be prohibited very clearly. The occupier or operator of common biomedical waste facility shall not dispose of such plastics by the incineration. The occupier or operator of the biomedical waste treatment facilities is dispose of or the recyclable biomedical waste such as plastics and glass, etc. through authorized recycler only. The Pollution Control Board grants the authorization for the recycling of the plastic waste. So they are giving separate licenses to those industries which are covered under the recycling of plastic waste. These rules are again of 2016, Ministry of Environment and Forest has notified. So whenever any hospital or clinical man gives the plastic waste, they have to see that the operator should have a recycling authorization properly. And without verification, they should not give it. In the event or breakages or of the mercury containing medical instrument, necessary precautions shall be taken by the occupier to segregate such waste as per the guideline published by the Government of India. Now I will give you some status about the biomedical waste generation in our country. Number of HCFs. We have 2,38,000 HCFs in our country. Number of bedded HCFs, that's 87,281. Number of beds in our country, we have a 20,94,000 approximately beds covered in our country. Non-bedded HCFs are 1,51,000. Number of common biomedical waste treatment facilities are 198. Number of HCFs having captive treatment facilities, these are 9,841. Number of captive incineration operated by the HCFs is 225. Quantity of biomedical waste generation in tons per day in our country is about 559 metric tons per day. And biomedical waste, what we are treating is 518 tons per day. Biomedical waste we are treating in our country. Remaining is being recycled. Next slide, please. Next. Next slide is for the packaging. Packaging and record. So we have to maintain the record. Next slide, please. Anyway, Madhu. Packaging and records. Here we have to keep the records for the packaging and maintain the how much quantity of the waste we have generated, how much waste we have segregated, and how much waste we have categorized within the hospital also. Now the comes is the annual report. This is a legal bounded things that every hospital, those who are obtained the authorizations under the provisions of the biomedical waste rules, has to submit the annual report by 30th June of every year with all the categorization and quantification. The prescribed authorities shall send the information to the Central Pollution and the State Pollution Control Board will inform to the Central Pollution Control Board by 31st July of every year. And the Central Pollution Control Board will inform to Ministry of Environment and Forest by 31st of August. So see how our rules are framed with each and every steps. State Pollution Control Board, Central Pollution Control Board, and Ministry of Environment and Forest. We have to maintain the records also. Regarding any accident, when any accident is occurred in any institution or the facility for any site where biomedical waste is handled or during transportation, see, during transportation of such waste, the authorized person shall report the accident in Form 1 to the prescribed authority, and they can do up any legal issues, they can do appeal in Form 5 within 30 days of the accident. Management of the waste, this is the now crucial period because of our COVID pandemic position. Keep separate color-coded bins, bags, and containers in wards and maintain proper segregation of waste as per biomedical waste rules. As precautions, double-layered bags, again I am telling, double-layered legs for the 2 bags should be used for collection of the waste from the COVID-19. Isolation wards as to ensure adequate strength and no leakages. Use a dedicated collection bins labeled as COVID-19 to store COVID-19 waste and keep separately in temporary storage room prior to handling over to the authorized staff of CBWTF. Used dedicated trolleys and collection bins in COVID-19 isolation ward. A labeled COVID-19 waste to be pasted on these items also. The inner and outer surface of the container bins trolleys used for the storage COVID-19 waste should be disinfected with 1% sodium hypochlorite solution. Biomedical waste is any generated from quarantine centers, camps, or should be collected separately in yellow colored bags suitable for biomedical waste collection. Persons taking care of quarantine homes, home care should deposited, biomedical waste should be deposited in the yellow bags at designated disposal center established by the urban local bodies. Report opening or operations of COVID-19 ward and COVID ICU ward to State Pollution Control Board and respectively the CBWTF sites located area. HCFs and the agencies operating sewage treatment plants continues to ensure the disinfection of the treated wastewater. This is really a challenging task. When the COVID patients are there, the wastewater, urine wastewater contains the COVID and which comes to the sewage treatment plant. So for that, this also precautions has been framed by the government of India. Operators of the ETPs and the STP attached with the discharge from the healthcare facility and isolation ward should adopt standard operating practice based on the hygienic precautions and wear personal protective equipment prescribed for the operators in the with the PPEs, which includes the goggles, gloves, face mask, liquid repellent cover, all waterproof gloves and water boots. During the COVID-19 pandemic, utilization of treated wastewater within HCFs may be avoided.
Patel sir, can you finish
some...
in 2 minutes, please, Patel sir? We are running short of time.
Yes, sir. Yes, sir. Yes, sir. Now I will show the. Please next slide, please. Next slide.
Hita, go to next slide.
Next slide, please. I would like to show the photograph of the incinerator. Next. This is the incinerator. See here, just for information to all our concern, this is incinerator is having a dual chamber and primary and secondary. Primary chambers having temperature of 850 degrees centigrade and secondary chambers should have 1050 degrees centigrade. Automatic feeding system should be there. Air pollution control devices like cyclones, scrubbers and venturi should be installed. PLC based control panel with graphical presentation of temperature, time should be there. Online monitoring of the measures for the CO and CO2 and O2 should be there. So these are the things. Next slide, please. Next. Next slide, please. Next. This is the photograph of autoclave. These are some photographs of the yellow beans incinerator and the blue and white, how to store and what to do with the sharp autoclave shredders. Next, autoclave shredders. I think this is the biggest task. Next, biggest task with us to tackle with the COVID pandemic waste management. And as far as our state and our country is concerned, in our state also, we have managed very nicely entire COVID isolated waste for the disposal of the treatment. As in the morning session, His Highness High Commissioner is telling about the biomedical waste. So these rules are really well designed by Ministry of Environment and Forest in our country, and we have adopted in entire country. Most of all the states are covered with the biomedical waste management system and working very smoothly. So thank you very much.
Thank you very much, Mr. Patel, for the wealth of information that you gave. Finally, because we are running out of time, I will not take more time. I will just request Mr. D.R. Pandya, the webinar coordinator and convener, to present the vote of thanks, please.
Thank you.
Thank you very much, Dharmendra Bhai. We had an excellent session of more than 2 hours, covering possibly all possible aspects of safety and infection control for the healthcare professionals. First, we started with the excellent motivational talk from His Highness Mr. Willie Brett, and it was followed by a very elaborate and very widely covering the infection control aspects in the regular healthcare establishment by Dr. Meena and Dr. Karnav Patel. Mr. Safari and Mr. Lawrence highlighted the laboratory practices, how infection controls can be starting from the specimen collection to the processing, and also the planning of the laboratory operations, how the infection control can take place. And lastly, Mr. V.R. Patel, last not but the most important aspect of controlling the infection was covered by Mr. Patel on the biomedical waste management. So thank you very much, all the dignitaries and speakers, and also the massive presentation today we had from the delegates, from the exhibition, from the webinar, and all. This is the end of our second day webinar. Tomorrow we will have a very important session on the technologies, quality requirements, and business operations opportunities for medical textiles, PPEs, and face masks. So I am sure this being a very important aspect regarding particularly the this COVID-19 pandemic situation, it will be of great interest to everybody. So I invite all to be there again tomorrow at 12 o'clock. Thank you very much. Thank you all, and look forward to your participation tomorrow.
Thank you. Thank you very much.
Thank you, sir.
Thank you.